So the title of my thesis is Towards Personalised Medicine in Metastatic Prostate Cancer, and I'm a PhD candidate in medical physics. And I just wanted to say a huge thank you to my supervisors, Jake Kendrick, Martin Ebert, and Mubasher Hassan, for being an incredible supervisory team through my master's and now my PhD, and I really couldn't have asked for a better team, so thank you. So prostate cancer is a highly prevalent disease with more than 26,000 cases diagnosed every single year in Australia. Now, if the disease metastasizes, unfortunately, only 3 in 10 men will survive for more than 5 years. My research is investigating how we can improve prognoses for patients with metastatic prostate cancer through personalized medicine. So what is personalized medicine? Well, in typical standard of care, patients will receive a set treatment, and some of those patients will have a positive response and some of those will have no effect or a negative effect. In personalized medicine, we stratify the patients into different groups and we give them the treatment that is going to be most suitable for them so that they can have a positive result. So my research comes in this patient stratification part where I'm trying to identify which of those patients are going to benefit the most from which treatment. So there are 2 types of prostate cancer that I'm looking to investigate, and the first is biochemically recurrent prostate cancer. This is an early disease stage which affects 20 to 40% of prostate cancer patients. It's marked by rising PSA levels, which is a blood marker of prostate cancer, and it is typically a predictor of future metastases. So we see in this patient, this person has biochemically recurrent disease and they have progressed to metastatic disease, meaning that they have lesions. This disease stage is typically treated with hormonal therapy, surgery, chemotherapy, or radiation therapy. So to image this type of disease, our gold standard image is called a PSMA PET scan, where PSMA is prostate-specific membrane antigen, which is a protein which is highly overexpressed in prostate cancer cells. So by doing the scan, we can cause those to light up and we can see exactly where the cancer is in the body. And this is a fusion between a PET scan and a CT scan. So this type of image has superior sensitivity and specificity compared to our conventional imaging. And the dataset that I have access to includes 238 patients with baseline scans and 200 patients with follow-up scans. So the aims for biochemically recurrent prostate cancer is first comparing response assessment frameworks for outcome prediction, and 2, reducing the time burden of RECIP, where RECIP is one of our response assessment frameworks. So what are response assessment frameworks? Well, this is a method of determining if a patient has progressive disease or not, using baseline scans and follow-up scans after someone goes through treatment. And there are 2 prominent frameworks that exist for these types of scans. The first is a lesion level assessment called the PSMA PET progression criteria. In this framework, progressive disease is defined as a new lesion between baseline and follow-up, or a growth in an existing lesion by at least 30%. Another one is called the response evaluation criteria in PSMA PET CT. This is a patient level assessment. So progressive disease is defined as a new lesion between baseline and follow-up, and also an increase in the total tumour volume by at least 20%. So for example, we see this patient has progressive disease by RECIP, as they have both new lesions and an increase in volume, whereas our first patient would only be considered to have progressive disease by PPP, as there's only a growth in the lesion, there are no new lesions. So this makes RECIP the more stringent criterion. Now, it's important to note that RECIP was developed for a much more advanced stage of prostate cancer, for the castration-resistant, and PPP was developed conceptually, so we don't have a lot of evidence to suggest that these are going to work well for earlier disease stages, such as biochemically recurrent disease. So here are some relevant studies. We see that almost all of them have data sets comprising of metastatic castration-resistant prostate cancer patients. And lots of these compared PPP and RECIP or saw how they correlated with outcomes. So there is a clear gap that we don't have much research looking at this early disease stage and how this tool might help identify high-risk patients. So this aim is actually completed. The paper has now been accepted for publication, and this is a subset of a few of these results. So these are Kaplan-Meier curves, survival curves, and what we see is that we can follow up the patient in time. And the purple is our progressive disease patients who were identified just after they received their follow-up scan. And we have up to 8 years of follow-up data on these patients. So what we see is that RECIP was able to identify a very high-risk group of patients, with only about 30% surviving after 7 years. So this means that RECIP was able to identify high-risk patients very early on. So clinicians can use this tool to definitively stratify their patients into high risk and low risk, and then they can administer further treatment to those high risk patients, which has the potential to save lives. Now, while we see that the results are promising, RECIP is a high burden tool. It requires doctors to segment every lesion on the baseline scan, do the same thing on the follow-up scan, and then match every lesion from baseline to follow-up to see are there new lesions or not. So my next aim is looking to reduce the time burden of this tool to make it more accessible. So one method is called visual RECIP. This was proposed by Gefita et al., which is the same group that proposed RECIP. And this is a qualitative assessment of disease progression. The doctor will just look at the baseline scan and look at the follow-up scan and make a judgment on whether that person has progressed or not. In their original paper, which was looking at metastatic castration-resistant prostate cancer, the much more advanced stage, they found excellent agreement between their qualitative and quantitative results and excellent agreement between readers. So we have repeated this for biochemically recurrent prostate cancer. And this is a tool that I have created using Python, which I've passed on to 2 clinicians. And preliminary results show moderate agreement between the qualitative and quantitative results and between readers, but further testing is still required. Following on from this, I'm going to repeat this assessment, but also apply overlays onto these patient scans. So I will apply organ segmentations using Total Segmentator, which is a common NN-unit-based framework for segmenting organs. And there is another proposed method by Salini et al., which has actually shown better dice compared to Total Segmentator. And additionally, I will apply lesion segmentations onto these images, which has already been developed by our team in the medical physics department. So this is the architecture developed by Salini et al. So they have a huge training set of over 4,000 scans, and they started with global localization followed by fine segmentation, and they got quite good results. So I'll be looking at using that. The next stage for automating this tool, or speeding it up, is a step-by-step approach. And in this approach, we're taking the clinician out of the picture and fully automating it. So firstly, I'll apply those same lesion segmentations. Then I will match the baseline and follow-up images together and apply a Hungarian algorithm for matching those lesions, which is something that is currently being developed by one of our master's students, Theo. And from there, that is all the information that we need to actually apply RECIP. The next method of automation that I'm looking at is a full deep learning approach using a Siamese network. This is where we have our baseline and follow-up as inputs. We have 2 identical encoders with the same weights, and we extract features. And then we combine those features in some way to look at the differences between those images. And then we can use that to categorize the patients as having progressive disease or not. So what are the implications of this? Well, we saw that RECIP is fairly high burden, but if one of these tools is very successful, we can potentially put this into the clinic and it can be used just at the click of a button, and we can identify patients that are at very high risk. This way, we can select patients who may need further treatment, which could potentially save lives. Okay, so moving on to the next type of prostate cancer that I'll be investigating, which is our much more advanced stage, castration-resistant prostate cancer. This is a stage where the patient no longer responds to traditional therapies and cancer will progress despite very low testosterone levels. So the imaging and therapy for this type of prostate cancer, this is called a SPECT scan, and patients typically undergo treatment using lutetium therapy, where lutetium is the radioactive part and PSMA is your ligand. The lutetium emits 2 types of radiation. It emits beta, which is used for the therapy, and it emits gamma, which we can use for imaging the patient. So the patient will be injected with the drug, it will go and seek out the cancerous regions in the body, and it will emit that radiation to destroy the cancer, as well as emit gamma radiation, which can then be imaged following treatment. So patients will often undergo something called a SPECT scan, a single photon emission computed tomography scan, a day after treatment. That looks like this. And this allows the clinician to see exactly how the drug was taken up by the body. And this is an example of theranostics, where we're using the same agent for both treatment and for imaging. So our aims for metastatic castration-resistant prostate cancer are as follows. I will be going into each of those in more detail now. So firstly, we have identifying prognostic biomarkers from pre-therapeutic PSMA PET-CT for lutetium therapy. So this aim is a literature review and a meta-analysis. Typically, patients will undergo a baseline scan, a PSMA PET scan, like I mentioned at the start, before they go through treatment. So I'm looking at if we can extract features from that baseline scan before they undergo treatment, and can we correlate that with the outcome of the patient? So far there have been two very prominent randomized trials that have investigated this. The first is called Therapy, which came out of Melbourne. And what they found is that the higher uptake of the drug in our baseline scan, the higher the likelihood of response. And they identified a cutoff of SUV10, which is your metric for uptake. And they said if patients are above 10, we should administer treatment, and if they're below 10, we should not administer treatment, as they will not have a high likelihood of treatment response. In another trial called Vision, which was a global study, they also found that higher SUV mean was associated with better outcomes. But they found that no cutoff point was better than another, unlike Therapy, which found a cutoff point of 10. And this graph here shows that at that 10 point, we don't necessarily see a significant drop-off at that point. 9 and 11 is quite similar. We see kind of a linear curve. So to me, this says that identifying a cutoff might not be the best idea, and rather we should look at this on a continuous scale. So I have begun the literature search so far, looking at these databases. I've identified 481 studies after duplicate removal, and after title and abstract screening, 104. And I'm just now in the process of extracting the data and doing the full text screening. So what I'm looking for is correlations between some of those baseline PET biomarkers and outcomes of the patient following treatment. And I will be doing this using Cox proportional hazards models and Kaplan-Meier curves. And I want to see if we can use these biomarkers for stratifying these patients into high risk and low risk, and identifying which patients will benefit the most from treatment. So here are some studies that I've identified so far. Most of them show that the higher SUV mean, the higher uptake, predicted response. However, there are some studies that don't show this, so the results do require aggregation, which is what I will be doing. And I have set up some data transfer agreements between Therapy and Vision, so I can do some patient-level data analysis. And I'll also be contacting some of these additional studies. Okay, so aim 4 is our deep learning lesion segmentation model for post-treatment SPECT CT. So SPECT images are fairly low resolution. So one of our limitations is that the quality of the image itself is low resolution. It's quite noisy. And I also don't have access to a huge sample size of SPECT images, so this provides a challenge for this aim. And also there is very little work currently in this space. I found 3 conference abstracts that were looking at segmentation models for SPECT scans, but it's a fairly novel area at this point. So the methodology for this aim, I'll be collecting the SPECT CT data and passing it on to an expert nuclear medicine physician who will perform these segmentations. I'll then split the data into our training, testing, and validation. And then I will explore some architectures for the actual lesion segmentation. So NNUNet is a model that is very widely used in the medical space for segmentation. So I'll first be exploring that as our baseline. I'll then be looking at MUMBA. So these two models, they do differ quite a lot. Our NNUNet is an example of a convolutional neural network, whereas MUMBA is a state-space model, and this can capture long-term information. So this may be more effective for our SPECT scans, as they are much lower resolution, and potentially we can capture those long-range effects where lesions are far apart, whereas our NNUNet is better at our fine edges, which are better for your high-resolution images. I'll be evaluating these 2 frameworks as well as other experimental frameworks using DICE similarity coefficient, Hausdorff distance, sensitivity, positive predictive value, and lesion level F1 score. After I am happy with the performance of this lesion segmentation model, I will then be extracting radiomics features. So radiomics features are deep imaging features such as textural features or shape-based features that we can't necessarily see with our eyes. and I will be assessing if those features are correlated with the outcome of the patient. Okay, and the last aim, aim 5, developing an automated personalized dosimetry tool. So just for a bit of background on this aim. When patients undergo treatment, we can measure the uptake in terms of dose in the organs and the lesions. And we can see that in most of our organs, we have quite a uniform uptake. However, in tumours, we have a huge range of dose uptake. And unlike in external beam radiation therapy, we don't have a strong understanding of how the uptake of the radiation is correlated with how well the person responds to treatment. So this is partly because performing dosimetry can be quite impractical. It requires patients to undergo multiple scans so that we can measure how the dose drops off over time. So in this aim, I'm looking at two parts of it. One, can we correlate tumour absorbed dose with the outcome? And two, can we develop an accurate method for single time point dosimetry aided by machine learning? So this is an example of the differences between using multiple time points and single time points. With multiple time points, we can create this curve. And in single time point, it's much more difficult to, we have a much greater uncertainty as we're not exactly sure how to fit this curve to it. So the methodology for this section, first I'll be applying those deep learning lesion segmentations that were developed in aim 4, as well as those organ segmentations. Then I'll perform multi-time point dosimetry. So this will come from multiple scans at various time points. And then from there, I'll correlate that absorbed dose with the outcome of the patient, for example, disease, response to treatment, toxicity, progression, and survival. From here, I'll perform some conventional single time point methods. These are the Handsheet and the Madsen methods. And then finally, I will train a model using the multi-time point dosimetry, and I'll also feed in some patient covariates to see if the model can outperform our traditional single time point methods. And then I'll compare the accuracy of those two models against also our multi-time point dosimetry. So implications of this. This will give us a better understanding of how dose relates to response to treatment. This will be a much easier implementation than having patients undergo multiple images at various time points. And if we have enough information, we can potentially change the dose administered for every patient, reducing toxicity while maintaining treatment efficacy. So ultimately, the end goal for the metastatic castration-resistant aims are to turn it into an automated pipeline. So the first part, which came from the meta-analysis, will be identifying those prognostic biomarkers for treatment. So that way we can identify which patients can benefit from treatment. The patient would then undergo treatment and receive just a single SPECT scan following treatment. And then the lesions will be segmented automatically using our aim 4. And then also our radiomics features will be extracted. And from here, this can inform treatment decisions. To conclude, these aims explore how existing clinical systems can be used to obtain more patient-specific information. By translating this information into treatment decisions, we can personalize care, potentially improving survival and quality of life of the patients. So just a little bit of my track record, recent publications and presentations. And I would just like to say thank you to the Forest Research Foundation and the Royal Perth Hospital for supporting my PhD, as well as the Charlie's Foundation for Research for supporting my PhD. And I would also like to acknowledge Pejman Ramshan Farshad, Jeremy Ong, Kenny Seck, Juliet Lee, Joel Noble, Nathaniel Barry, and many other people who have already played a really significant part in my PhD. So thank you very much. And here are my references.